Now we move to sexual dysfunction. Sexual dysfunction is when one or more phases of the sexual response cycle are not completed. When we look at the prevalence of sexual dysfunction, this is one of the best areas of information. A national survey, a face-to-face interview of 1,000 men and women published in the Journal of the American Medical Association, ages 18 to 59. And they found the prevalence of sexual dysfunction was 43% in women and 31% in men. That's a huge percentage. If this isn't an epidemic, I don't know what an epidemic is. Now, in terms of the exam, what is the most common female sexual dysfunction? And it is low sexual desire. That would be good to remember for the exam. Arousal disorder, 14%, 7% pain with intercourse, but 22% low sexual desire. That's 1 out of 5 women. Do you think the most common male sexual dysfunction was low sexual desire? No. 21% premature ejaculation, and then erectile dysfunction, 5%, and low desire was only 5%. So premature ejaculation is the number one in males, and low sexual desire is the most common one in females. Now, it's important to realize when we talk about sexual dysfunction that according to the DSM-4, which is the psychiatric definition for disorders, we can have sexual dysfunction in terms of desire, in terms of arousal, in terms of orgasm, and in terms of pain. But in addition, they say that the disturbance must cause distress or interpersonal difficulty. Is the woman distressed over it? And that's really important to keep in mind. For instance, let's look at 2 patients here. And we look at what is her desire for sexual activity. This is the level of desire for patient A. This is the level of sexual desire for B. Who has the sexual dysfunction? And you can't say that this patient has a sexual dysfunction just because she doesn't have much desire, because the key question is she distressed over it or not? And for many women, they may not be sexually active, and that's perfectly fine. That's not a problem for them. Okay, let's look at the various sexual dysfunctions. They can impact on desire, excitement, orgasm, or pain with intercourse. The desire, decreased desire, 50% success rate only in treatment. Some of the causes are decreased testosterone if you do a hysterectomy and oophorectomy on a premenopausal or even postmenopausal woman. SSRIs, which decrease desire, oral contraceptive pills, which can suppress your androgen production. Now, these can be usually pretty easily be handled. These are medication related. But if there is a partner problem, if she's married to a jerk, is there any surprise that she has no desire? And unless both partners recognize and are willing to go to therapy, 50% success rate. Decreased excitement. This is failure for the engorgement to occur. This may be an estrogen-related phenomenon after menopause, if there is hypoestrogenic state, and decreased lubrication. Now, these can be usually addressed with lubricants or hormone replacement, 80% success. Anorgasmia. Inadequate stimulation is usually the main reason. The woman doesn't know where she gets her pleasure from. Once she can find that and can teach her partner, 90% success rate. Pain with intercourse is important. And we've talked about many causes of that. Many of these are biological, they're medical, they can be endometriosis, they can be PID, they could be vulvar lesions, they could be vaginal infections. This needs a thorough medical workup. Don't just say it is psychological until you have done adequate workup. Now, vaginismus is a somewhat unique sexual dysfunction. This is where there is involuntary adductor thigh muscle contraction. She can't get her legs apart. This is the only sexual dysfunction which is diagnosed or can be diagnosed by exam. All the rest of these are by history alone. This is usually of psychological etiology, either from a very repressed or conservative upbringing, and this can be treated very successfully in most patients. Okay, this slide looks at vulvar and vaginal tenderness, which occurs with a condition called vulvodynia. And this is one of the medical causes of painful intercourse, which needs to be thoroughly examined. And the numbers here are showing where you need to check for tenderness. And the main thing I want to say is that painful intercourse needs to be thoroughly evaluated medically. This is looking at the treatment for vaginismus. And these are vaginal dilators of various sizes. If the patient can see that she can safely and comfortably insert a small vaginal dilator and gradually work her way up to where she can accommodate normal sexual intercourse, these can be very, very helpful. This slide shows how vaginismus becomes a vicious cycle and how those involuntary muscle contractions take over. She has pain, which leads to anxiety, decreased lubrication because she's not relaxed. Then with penetration, there is pain, leads to more contractions, and the thing becomes a positive feedback cycle. You want to have a negative feedback cycle, not a positive feedback cycle. This is a a natural supplement, Peru's maca root supplement is the testosterone patch alternative. What do you think? I don't know. This is a study looking at sexual function and hysterectomy, and this is removing the uterus. No problem in taking out the uterus for women who need a hysterectomy, and I think that's reassuring. This is not talking about removing the ovaries, however. Study finds frequent sex may cut cancer risk. Contrary to some research, frequent sexual activity does not increase the risk of developing prostate cancer, may even reduce the danger. Very interesting. Okay, let's just take a minute to talk about Viagra. How does Viagra work? Viagra works by maintaining the vasodilatation of the corpus cavernosum of the penis. Nitric oxide stimulates cyclic guanosine monophosphate, which is responsible for the vasodilation. Phosphodiesterase 5 degrades cyclic guanosine monophosphate and leads to loss of the erection. Viagra, or the generic name, is sildenafil. It interferes with the degradation of the cyclic GMP, and that's how Viagra works. Good board question on that. If Viagra works for men, is it possible that there could be Viagra-like medications for women? And there have been a variety which have tried sildenafil, phentolamine, apomorphine, other creams. Do they work? The initial findings, this was a 12-week study on 202 postmenopausal, post-hysterectomy women, said that Viagra did work. After 3,000 women were studied, Pfizer came to the conclusion, and Pfizer is the company that makes Viagra, that it really doesn't work on women. The studies were inconclusive. Why is that? Because women are far more complex than men. This is a woman. And how does she work? And you can see, very complex. Compare that to a man. Fairly simple. When you look at the erogenous zones of a woman, they're multiple. Men are far more simple. The erogenous zones of a man. All right, that is the end of sexual dysfunction.